So good morning, assuming you're in the Eastern U.S., depending on wherever else you might be. Good evening, good night. We today are going to be talking about eyes and diabetes. When we were at Hopkins, we thought that Wilmer Eye Institute was one of the best in the country, and it is one of the best. There's no question. You could still argue that. But there are a lot of places that have their own claim to fame. One of those is the Bascom Palmer Eye Center at the University of Miami. Our guest today would certainly say that's the best place in the world. He's done a lot of work with them, a lot of research with them. His name is Craig Brown. He's an ophthalmologist. We'll introduce Craig. He's got about 40 years worth of practice in helping people save their eyesight. And we're going to talk about a couple of key things. You know, if you have listened to Z-Dog MD, many people have heard him. His channel's far bigger than ours. He does a lot of silly songs, but he's got some serious components to his channel as well. One time he covered methylation, MTHFR. His perspective was, like most doctors, oh yeah, it's real, but it's not significant. Well, Z-Dog MD is an intensivist. In his job, he sees people for a couple of days in an ICU, and then they're gone. Well, if you're working with people year after year and working to save their sight, methylation makes a difference. It makes a big difference. And we're going to go into some of that today. As most of the folks who've followed this channel anytime, they know that prediabetes and diabetes make a big, big difference as well. And in fact, it depends on the research that you look at, the science you look at. There's a very significant number of people who already have diabetic eye disease, diabetic retinopathy, by the time they've been diagnosed. In fact, let me see if I can go over to, there was, I've covered several different, let me see, are you able to see my screen? There we go. I'm going to cover a couple of quick things, Craig, before we get started. You know, I've said many times that between 20% and 60% of people, by the time they get a diagnosis of type 2 diabetes, already have diabetic eye damage. What does that mean? Does that, many times I've said, well, because most diabetes is diagnosed way too late. People have had it for years, if not decades, before it ever gets diagnosed. There's another component to that as well, and that was in this recent study where they said, look, the damage is starting before the diagnosis of diabetes as well. On these three slides, this group, this was, by the way, this was published in Diabetes Care way back in 2009. And they're talking about the role of A1C in diagnosis. But one of the things they did was graph eye disease by fasting plasma glucose, which was the old standard way of diagnosing diabetes, the 2-hour OGTT number, peak number, and the hemoglobin A1C. Hemoglobin A1C, you typically will say, okay, 6.5 and you have diabetes. Well, the 2-hour peak, 200 and above, and you have diabetes. Fasting plasma glucose, 125 and above, and you have diabetes. Well, if you start looking at eye disease, the eye disease starts before those cut points, 116, 185, 6.0 for hemoglobin A1C. So there's two major reasons why so many people already have diabetic eye disease before they're even diagnosed. Now, again, as I often do, I digress. So let's go back to the discussion today. We're going to talk about just what is diabetic eye disease. We've got a as you will see, a significant expert in this area. He's helped tens of thousands of people save their eyesight. We're going to cover these 5 questions specifically. What's diabetic retinopathy? Why does it matter? What is MTHFR? Methylation problems. What does that mean? Why does it impact diabetics? Why does ocufolin make a difference in MTHFR and diabetic retinopathy? Why do you recommend methylcobalamin versus cyanocobalamin? And why is vitamin D important to eye health? So we will get there. Before we do, just a brief summary of, for those of us who don't know the channel, the types of content that we have available, other types of content. We've got about 1,000 videos ranging from NAD plus and other niacin related supplements to discussions with, excuse me, I'm going to have to get some water in just a minute, I think. Discussions with Dr. Kevin McCord. He'll be doing more work with the channel. He's a family practitioner who came to see me when he had a cardiac event. And then as he began to get treatment for that cardiac event, he realized just what so many people on this channel have realized, that he'd had some diabetes problems going on that he was not aware of. So again, we've got a lot of content, a lot of it focusing on helping people understand the damage that's being created in over 100,000 Americans alone with undiagnosed prediabetes and diabetes. We've got webinars on it. We've got, one of the typical reasons for coming to see us is, hey, doc, I got a positive calcium score. My doc just says, here, take more statin. We will talk a lot about supplements today. Supplements is a very popular topic, and we have a whole webinar which we provide to help people get a much more of a basic understanding of supplements. We don't suggest that you fire your doc, but we do suggest that you understand there are places where, I mean, my old colleagues at Hopkins have been the first guys to document. Your typical doctor in the U.S. today does not understand prediabetes well enough to diagnose it, let alone manage it. So there may be places where you need to just get a little bit of extra help. So our work is expensive. We've developed some subscription programs to make it a little bit easier to get that done. We've also got courses. I mean, for what, 20, 30 bucks, you can know more about insulin resistance, plaque, cardiovascular inflammation, and our entire content than over 90% of docs. So we're trying to get that content out there. Speaking of content, I heard from Todd Eldridge. You know, we got to the end and we realized we did not have a good chapter on CIMT in terms of the book on how to recognize plaque. As you see on this image, Tim Russert may be the posthumous poster boy for how not to recognize plaque. He was having some problems. He went to his doc. He said, "Hey, I'm gaining weight. My blood pressure's getting a little bit more out of control. There's a family history here. Why don't we just do a stress test?" They did a stress test. He passed it with flying colors. He was a big runner, passionate runner. So he said, you know what? Okay, good. He breathed a sigh of relief, went back to work, and a couple of months later was doing a voiceover for Meet the Press and keeled over with a heart attack and died. And it's because they didn't understand what they needed to understand about his plaque at the time. So there's better ways these days of understanding how much plaque you have in your arteries, how much risk you have, and how to deal with it. We've been working a lot on our website. We've been getting podcasts up and available, and those are becoming very popular. So again, there's a lot of content. Don't complain to us about being expensive. We're getting as much free content as we can out there. Speaking of which, we're going to talk about A lot of free content, a lot of really good free science on eyeballs, diabetes. So why don't we start with Dr. Craig Brown? Dr. Brown, as I said, has been working for over 40 years as an ophthalmologist. He's performed over 9,000 cataract operations, thousands of ophthalmic laser operations, and as I mentioned before, has been doing a lot of work specific to research in MTHFR, supplementation, a thing called medical foods, which we'll talk about in just a few minutes. And one of the things that I find the most interesting, Dr. Brown, is your time in Ghana as a medical missionary. You want to give us a few seconds about that?
Well, fresh out of medical school, I went over and spent just under a year working in a hospital up in northern Ghana. And I saw infectious disease, public health issues, things that I had only read about. And I learned a lot about the culture, about the culture of medicine, about things that we take for granted, like grocery stores and clean food. And I would see people die uh, because they didn't have $2 worth of antibiotics, and everybody had malaria. It was just a completely different experience, and that one day had a guy with a big tumor on his foot, and I'm not an orthopedic surgeon, but I got out an anatomy book and I took off his foot because the tumor had to go. And it taught me to be resourceful and to not always be waiting for some authority to tell me how to do it perfectly. Because sometimes better is the enemy of good.
There's an old adage in medical training, see one, do one, teach one. And it talks to that point about sometimes you can study too much and the patient can suffer while you're studying. And you learn a lot about that at Charity. I learned a lot about that at Charity Hospital in New Orleans, where I interned.
Yes.
So let's talk about some eyes for just a minute. First of all, what is diabetic retinopathy and why does it matter?
Well, diabetic retinopathy is vascular disease caused by diabetes. It's damage to the blood vessels of the eye. The eye needs more food and oxygen than any other organ of the body. That's why when you faint, your heart stops, your vision goes first, and then your brain goes down next. There's about 13 million diabetic retinopathy patients in the US, and as you said, half are undiagnosed. Eventually, diabetic retinopathy leads to blindness. Sooner if you have genetic defects like MTHFR or malnutrition. Most people over 50 have several risk factors. With average diabetes treatment, blindness starts about 11 years after diagnosis. Poor lifestyles, nutrition, bad genetics make you more likely to get the complications of diabetes, which are retinopathy, heart disease, peripheral neuropathy, and kidney disease. There's two current treatments for diabetic retinopathy. We can either burn 2/3 of the laser out with the laser and you lose your side vision and night vision, or we can stick a needle in the eye and inject expensive medications about every 6 to 12 weeks. So it seems to me that targeting lifestyle, diets, using products like Ocufolin are a good way for diabetics to get a lot more years before they need the needle and the laser, maybe avoid it altogether.
Great summary. You know, when we were talking, I forgot to ask you, earlier this morning, I sent you my little video on my Drews. I'm guessing you didn't get a chance to see that yet, did you?
I saw it.
So, as we discussed, I'm a heterozygous MTHFR, poor methylator, 63 years old, have had prediabetes that I've known of for about pushing a decade now. I did have one episode with a recorded blood sugar over 200. So you could say I meet the criteria for full-blown diabetes. So tell me, I'm assuming that having only one druze at this point in life is pretty good. Am I wrong, or what's the story there?
I'd rather not see any. What comes to mind is if you don't have a family history of macular degeneration, then I wouldn't worry about it. But if you have people in your family that went blind from macular degeneration, then it's kind of a warning sign, and you ought to do the things with the supplements and the lifestyle that we know that reduces macular degeneration. That's a whole nother talk, and I've got lots of ammunition in that cannon too.
Well, before we go down, this channel and I myself am notorious for going down bunny holes. So before we go down that bunny hole, let's go back up to the basics and talk about the types of diabetic retinopathy.
The types of, well, there's two main types of diabetic retinopathy. There's proliferative and non-proliferative. The initial stage is non-proliferative, where you just have damage to the vascular endothelium and you get perfusion damage, leakage. Beginning at the stage of early prediabetes, you begin to see loss of vascular density in the retina. You begin to see decrease in blood flow. It gets worse with diabetes, and it's a complete it's up till now it's been considered to be an irreversible downhill trend. What was exciting about Ocufolin was we began to reverse that trend of blood flow and vascular density loss in diabetes and began to move back towards normal. But there's the non-proliferative stage. When you get enough of the blood vessels damaged, then you get capillary dropout, you get ischemia, you get nerve fiber layer infarcts, and then you start secreting vascular endothelial growth hormone, which is the body's way of getting more blood vessels. So new blood vessels grow, new blood vessels proliferative. And the problem is in the eye, they tend to rupture and bleed, and then the blood forms a scaffold that causes scar tissue, which normally is a good thing, but in the eye causes detached retina.
So you're talking a lot about small blood vessels, and it's an interesting point. The majority of this channel is all about preventing heart attack. Now, my typical patient will say to me, after about 6 months to 18 months of working with me, my typical patient will say, doc, I've rethought this stuff, and you may think I'm crazy, but I'm actually a lot less worried about a heart attack than I am dementia. And I know that a lot of the stuff that we're doing here helps prevent dementia as well. Well, of course it does. I mean, what we're talking about here is protecting those small vessels, those small arteries. Any comments about that?
Yes. Well, they say the eye is the window of the soul, and it's certainly the window of the brain, because the blood vessels of the retina and the retina itself embryologically come from the brain. And so when you're looking at the retina and you're looking at the blood vessels of the retina, you're looking at exactly the same blood vessels and tissue type. That's whatever's going on in the retina is going on in the brain. And it's interesting that Dr. Wang, who is the principal investigator in our studies with Ocufolin, has just received a 1.4 million grant from NIH to correlate retinal blood flow with brain blood flow as part of a dementia push from NIH.
So there must be a significant overlap between diabetic retinopathy and dementia.
Oh yeah. Vascular diabetes, I think you could say, causes vascular dementia, and about half of the people that we say have Alzheimer's really have vascular dementia. And you put them on the program, the lifestyle program, and you put them on Ocufolin, and you will see their cognitive function improve, their MRIs improve. It's pretty amazing.
A lot of the world-class scientists, the kind of guys that are publishing on this kind of stuff in Nature magazine are calling dementia type 3 diabetes. I
Yeah,
did
I've heard
I
that.
did
That's good.
I did some work with Dale Bredesen in basically just getting training for attending some of his training programs for uh, management of diabetes of dementia. And he came up and asked me after the program what I thought, and I hesitated for a bit and he could tell. And I said, "Well, here's the thing." I said, "It was a great 2 days, but it was really focused a lot on management of advanced dementia, and even more so, there was only out of the 2 days, there was only 2 half-hour sessions on prediabetes." And he looked at me kind of funny and cocked his head, and he said, "Yeah." And I said, in a very, I made some assumption that he was not as deep on that connection as I was. I said, "Well, I thought at least half of dementia was prediabetes, caused by prediabetes." He looked at me for a second. He said, "No, I think that's low. I think it's all of it." And in fact, there's a lot of people that don't have known prediabetes, but they have what we call central nervous system diabetes. And he mentioned the fact that many of us know that insulin in and of itself is a critical part of forming short-term and long-term memory. And he didn't go into the Wake Forest studies in terms of inhaled insulin and things in that space. But my perspective, and I didn't go into this with him, was, yep. And I think a lot of those people have had prediabetes for decades. They just did not know how to diagnose it. So, yep, we continue to connect dots. We go down what seems to be a bunny hole and then come out the other end. And again, the damage being done by unrecognized prediabetes and diabetes is just devastating. Speaking of which, as we mentioned before, I belong to a group, and it's not a small group at all. It's significantly over half of us that are at significant risk for this issue due to the fact that we don't methylate very well. You want to talk for a minute about homocysteinemia and methylators?
Well, what you're saying in the big picture, it's all about the blood vessels because the blood vessels deliver the nutrients and the nourishment, and they haul away the garbage. And you have so anything that damages the blood vessels is going to show up first in the eyes, next in the brain, then in the peripheral nervous system, and later on, years later, in the heart and the kidneys and things like that. And homocysteine is one of the controllable risk factors that we can deal with. You don't smoke, you keep your blood pressure down, you keep your blood sugar down, and you control homocysteine. And you can control homocysteine with, as the chart up here talks about, with L-methylfolate, vitamin B6, vitamin B2 riboflavin, and methyl B12. So with those and another substance called trimethylglycine, you can lower homocysteine down to an ideal level in over 90% of the patients. And homocysteine has been shown to damage the blood vessels, to damage the capillaries. If you inject homocysteine inside the eye, you can just watch the retina melt and die.
Mm.
It's the lower the homocysteine, the better. It's not like cholesterol that you can go too low. You can't go too low on homocysteine, but it's pretty hard to get below 6. But the all-cause mortality rates on homocysteine, the kind of a break point is at 9. So if you can get below 9, you're really going to shift the needle. And homocysteine damages the blood vessels, the endothelium. And if you think of a capillary, which is where the nourishment goes in and out, it's basically just an endothelial bag. And so you damage that, you've damaged the whole system. And because the eye has the highest oxygen and nutrient demand of the body, the eye has the highest blood flow of the body per gram of tissue. And the macula is the highest of all because that's where the highest density of photoreceptors are. And you start seeing things like drusen and diabetic retinopathy. It often shows up right there in the center around the macula. And so one of the things you can do to reduce risk of diabetes and diabetic retinopathy is lower the homocysteine.
And how do you do that?
The simplest way is to take some sort of supplementary high doses of vitamin B2 riboflavin, vitamin B6 pyridoxal 5-phosphate, L-methylfolate, and methylcobalamin. And you don't want the junk cheap stuff. You want the natural forms of the vitamins that's a meal already cooked.
So what would be the junk and what would be the natural stuff?
Well, there's only one kind of riboflavin, so that's okay. Pyridoxine is the degraded form of B6 that's in most vitamins, but P5P or pyridoxal 5-phosphate is the active form, and it's the always non-toxic form. Folic acid is the synthetic that they put in all of our foods, but it's very hard for the body, especially with those of us that have MTHFR defects like you and me, very hard for them to convert it to L-methylfolate. So give the natural form of L-methylfolate, and it's a meal already cooked and ready to go to work. And the same thing for cobalamin. Methylcobalamin is a meal already cooked, ready to go to work, ready to donate that methyl group, which knocks out the homocysteine. And you don't, and the other side of that is the other reason you don't want to take the junk B12 is cyanocobalamin, which is what's in most vitamins, most of the thing you find on the drugstore. Cyanocobalamin is a synthetic form of B12 that is 2% cyanide by weight. And it's okay for a young, healthy person, but if you've got a diabetic that's got some early kidney damage, you don't want that 2% cyanide metabolizing in the kidneys. And occasionally that can be fatal for patients with advanced diabetic renal disease. So because the methylcobalamin is always non-toxic, and because the methylcobalamin has the methyl group to immediately neutralize the homocysteine, it's much more effective than cyanocobalamin.
So that's very helpful. For those of us who have studied this is not the first time that we've heard, don't use the cyano. Cyano is a cyanide moiety. And for most people, it doesn't cause a problem. But for some people, there may be an issue. I'm going to ask you to walk us through these slides of the eyeball. But before I do, I'd like to give my own brief explanation of this antioxidant issue, the methylation issue, and where it fits more globally. If you go back to high school and college biochemistry, we have a thing called antioxidants. If you look at the Krebs cycle, you look at the basics of how we metabolize. We as humans have significant advantages over yeast, for example. A yeast will get 6 energy units out of a molecule of glucose. We, on the other hand, get 36. The reason we do is we have an oxidation component. That oxidation component is linked, as many of us learned in high school chemistry, to combining oxygen with a substrate or a fuel. Well, glucose is the fuel here, and some other things. Oxygen is being transported in from hemoglobin. That's why this whole process of breathing and hemoglobin exists. Well, those of us who've studied aging know that the mitochondrial theory of aging is one of the most dominant theories about mechanisms of aging. You know, it's like if the mitochondria are the furnaces of the cell, then, you know, just like any other furnace that's been burning stuff for 60 years, sometimes those burning embers burn a hole through the side of the furnace, and you've got these burning embers lying around. That's basically the very informal presentation of the mitochondrial theory of aging. So that then creates a whole new industry, the antioxidants industry. You know, people think of vitamins A, C, and E as the antioxidants, and they are. But really, when you look at how the human body does this, the human body does antioxidants or reduction in a slightly different way. To go back to high school and college chemistry, oxidation is the addition of an oxygen molecule, and reduction or reversal of that is simply another addition of hydrogen molecules. The human body does not do that. We don't add a hydrogen molecule. We add a methyl, what we call a moiety or portion of a molecule, a methyl molecule. That's 1 carbon, 3 hydrogens. Now, it accomplishes the same thing. It neutralizes all of those oxidants that are lying around. So why would we want to take vitamins A, C, and E when our own body really doesn't do that? Our body uses methylation, methyl groups, because as Craig and I are talking about, many of us have genetic problems with that process. The mutations, and they're well known, C677T and A1298C are two of the most common. I've got one copy of one on one gene and another copy of the other on the other gene. And so my body doesn't methylate very well. Now, it's fairly simple to deal with that. And it's exactly what Craig has been talking about. You replace it. There's some over-the-counter versions. Those of you who go into Amazon, we'll lose, what's the word I'm looking for? Monetization on this film, because I'm going to mention a few labels. Thorn Methylguard or Methylguard Plus. That is, you can get that on Amazon, and it is basically a group of B vitamins that have already been methylated. Now, as Craig talked about a few minutes ago, there's some significant advantages and disadvantages regarding which preparation of methylated B complex vitamins you take. But the whole purpose of the past minute and a half was to help us put all of this methylation in perspective. Craig, I went down a long bunny hole. Any comments or desire to bring us back to the topic?
Well, because these systems are interconnected, these B vitamins indirectly act as antioxidants because they impact glutathione, which is a cysteine-based compound. And the other thing is that the antioxidants not only directly quench, but they recycle glutathione, which is the master antioxidant in the mitochondria. So I always think of these things as, what can I do to help glutathione? Okay, I'm going to put some C and some E and some lutein and zeaxanthin and alpha lipoic acid and some other things to help that. And then I'm going to give N-acetylcysteine, which is a substrate that's the backbone molecule that can then be easily converted into glutathione. So to me, it's all about decreasing homocysteine and raising glutathione.
Exactly. I'm blanking on his name. He's a prevention guy that's much more well known than either of us, and he calls glutathione the mother of antioxidants.
Mark Hyman.
Yep, that's right, Mark Hyman. So, are you ready to tell us a little bit about these slides, these pictures of eyeballs
Sure,
and what they mean?
sure. Well, these were, let's start with the mild. We were talking about early diabetic retinopathy. When you find it, you usually find one or two hemorrhages, a little bit of exudates. And the picture's a little small, but if you look on that mild diabetic retinopathy 10-month recovery, you can see there's the optic nerve, which is the light colored thing, the dark colored spot, which is the macula. And then up above the dark colored spot, you see a red spot that's a hemorrhage. And in larger pictures, you can see a ring of lipid exudates around it. And we started them on this. And over a 10-month period, it completely went away. Follow-up pictures 2 or 3 years later shows it stayed gone. So the one on the top right, the severe diabetic retinopathy, that's 3-year follow-up. And the pictures almost don't do justice. You can't quite, but this person was down to kind of count fingers vision and 20 vision lost. It had already had lots of laser. You can see it burned out a lot of his retina, and gave it to him. I'll never forget that he came shuffling in with a walker and dark sunglasses and just non-functional. And 3 years afterwards, he came in and I actually didn't recognize him. And he was driving again. He got enough side vision back to the one eye that was 20/30. But you can see on the right image, you can see the white lines. Those are actually occluded retinal blood vessels that, I mean, those are gone forever. So that, yeah. But it doesn't have the little spotty hemorrhages. So we arrested the progression in the left eye. In the right eye, we had more to work with. And in the larger enlargements of it, you can see lots of fleck hemorrhages that have gone away. And you can see the swelling in the retina has gone down. And he's now 20/30 and driving a car and just a different person. Yes.
Wow.
Then this other, one of the big problems with diabetic retinopathy is you get occlusion of the veins and arteries. And this is a fellow that came in, was sent in with a hemorrhage. His optometrist saw a hemorrhage, sent him to me. And so first thing I did is I worked him up for hypertension and diabetes and all that. And sure enough, he had undiagnosed hypertension and diabetes. So we treated that, put him on the ocufolin, and you could see over a 10-month period that recovered. Now, normally that's a 2 or 3 year period. And the average vision recovery after that kind of thing is about 20/50 or 20/60 vision, right on the borderline of being able to drive. And in 10 months, he was 20/20. And lots of those. So this is out of the trial at Bascom Palmer at the University of Miami, where we took just early mild diabetic retinopathy, and we were just studying the blood flow and the tissue density of this. But we did check visual acuity at each visit, and you can see that that they started out between 2025 and 2030, and their vision was getting into the 20/20 minus range at 4 and 6 months. And what I've noticed clinically in taking care of people is I still can see visible improvements out to 3 years. So my guess is that vision would have continued, but even at 6 months, we were seeing improved vision, which is kind of like the fellow in the upper right-hand corner.
Very helpful. So before we open up for questions, I remembered we promised we were going to give you a chance to talk about vitamin D. You want to make a comment about that?
Yeah. Well, okay. Vitamin D regulates cell membrane interactions, and it's so important for so many things. As you know, Ford, y'all have talked about that. In my mind, when I think of vitamin D, deficiency in vitamin D increases harmful inflammation. So Deficiency in vitamin D creates harmful inflammation, increases the risk and severity of diabetes, increases the risk and severity of diabetic retinopathy, increases the risk and severity of macular degeneration, increases the risk and severity of heart disease, and it reduces the absorption of L-methylfolate, which is key to fixing the homocysteine and the endothelium. And of course, it shortens lifespan. Other than that, vitamin D is not very important. Oh, and I didn't mention cancer and osteoporosis.
So other than that, not very important.
Other than
Let's do one other quick slide for the group. You know, we go down a bunch of bunny holes, but people often will come back and say, well, wait a minute, just give me the short version. What can I do to protect my eyes?
Number one, don't smoke. If you smoke, stop now. Number two, make sure your blood pressure, your blood sugar averages below 100. Make sure your blood pressure is below 130/85. Whatever it takes to get to there, do that. Then exercise 150 minutes a week, at least. Then you can start looking at supplements. And supplements, I think, in order of importance are methyl B12, vitamin D3, L-methylfolate, pyridoxal 5-phosphate version of B6, riboflavin, and thiamine, vitamin B1, because thiamine protects, higher doses of thiamine protects the vascular endothelium from surges of blood sugar. So it blocks damage from advanced glycation end products, AGEs. So those are the basic things. And when you start talking about all the vitamins, it's really hard to get a vitamin with all of them in the right format. And then you wonder, well, this vitamin was made in some third world country where the FDA can't inspect it. You don't know what the cleanliness and purity of it. So we create, is this the place, so we created a product that was made in the US to high purity, have it as a medical food. So it's dispensed by a physician and monitored. And it's all the right stuff in all the right amounts. And as you can see on the studies, it gets results, and both from the photographs and from the studies we are publishing out of Baskin Palmer. And this handout sheet is kind of a shortcut that we can make available to people if they would like.
Thank you very much. And again, I think it goes back to that same theme of diabetes, prediabetes, and our arteries. So diabetes, prediabetes only damage tissues that are supplied by arteries, which means obviously the retina of the eyeball, the brain, nerves, kidneys, our erectile mechanisms, our legs, our hearts, you name it. Thank you again so much for what you've provided for us. What we'll do very quickly is a quick little NIH explanation of retinopathy, and then Aspen can give us the water ball, and we'll go into some Q&A.
The Comprehensive Dilated Eye Exam, opening the door to preventing blindness. A doctor can detect signs of diabetic retinopathy during a comprehensive dilated eye exam. The patient receives special eye drops that dilate the pupils. The pupils open wide, allowing the doctor to see the back of the eye clearly. When eyes are dilated, the doctor can clearly see the retina, optic nerve, and the macula. Early diabetic retinopathy starts with small red dots called microaneurysms and can progress to leaking blood vessels, causing thickening of the retina and blurring of vision, or new blood vessel growth that can bleed and cause blindness. If you have diabetes, you are at risk for diabetic retinopathy. Dilation enables doctors to get a better view of the back of the eye, which allows them to determine whether there are early symptoms of disease. But it's important to know that all people older than 60 need a comprehensive dilated eye exam each year and should inform their doctor right away if they begin to have problems with their sight. People at higher risk may need to have a dilated eye exam more often. Risk factors, including race, age, and family history, are all important to determine how often patients should receive a comprehensive dilated eye exam.
So what we'll do now is go into let me read a few comments and questions, and then we'll see who should take which. Just a few hellos. Amir Al-Gayer. Amir is from Germany and attends a lot. Bart, good morning, Bart. Arthur Berry. Geraldine from France. Lisa from Denmark, and Frederick from Indonesia. Amir says his LDL is 95, HDL is 85, triglycerides is 36. A couple of quick comments. You usually don't get an HDL of 85 and triglycerides of 36 without managing your carbs pretty well. You know, one of the things that we continue to tell people to look out for in terms of their own carb metabolism and diabetes risk is the triglyceride over HDL ratio. At 1.5, I start getting nervous for folks, and yours is less than 1/2. So excellent work, Amir. Richardson 75080 from Dallas. Robert Simpson. This is a great topic, Robert. Is it better to have a PCP, primary care physician, or an endocrinologist to manage diabetes? So here's the thing. There are not enough endocrinologists to go around. This is an unfortunate thing, and it's something where I have said many, many times, despite the fact that it's clearly a life or death and quality of life, disability, dementia issue, heart attack issue, management of prediabetes is a buyer beware market issue. That's bad, but it's the truth. If you look at the actual evidence, again, as I mentioned before, the science is pretty clear with demonstrating that less than 1/3 of primary care docs understand how to diagnose prediabetes, let alone how to manage it. Here's the thing. Endocrinologists are somewhat like the rest of doctors, even primary care docs, and you see this with dentists. They get up every morning, they go to work. Dentists see so many people with bleeding gums, they begin to just get used to it and think, that's just what's going to happen, and they don't even mention it to their patients. Same thing with endocrinologists. They are so swamped with people with significant, major diabetic, way down the road issues. You don't see a lot of endocrinologists that are focusing on this early diagnosis, this prevention focus. Any comments, Craig?
I couldn't agree with you more. I find it's really hard to get people aggressive care, and prevention is better than cure. And you've got a chance to turn it around. I used to have this experience where the family practice people would send me their diabetics at first diagnosis because I would scare the living hell out of them and say, if you don't do this, you're going to be blind in 5 or 6 years. So you do what the doctor says. And they come back and say they're much more compliant after I've read them the Riot Act. Because as an internist once said, the only 2 things that my patients are interested in is, can I pee and can I see?
Yeah. Well, you'll see that the viewers on this channel have a little bit deeper interest and a lot more sophistication. In fact,
yes,
the typical viewer of this channel knows far more about this topic than your typical doctor.
Yes.
The Shimobi at Emir, good labs, I would agree. Martha Reich, good morning. In case this hasn't been addressed yet, should all adults over a certain age have an evaluation visit with an ophthalmologist?
Well, the problem you said about endocrinologists is exactly the same problem we have about ophthalmologists. Uh, Most ophthalmologists coming out are just overwhelmed by the amount of surgery volume. And so they're tending more and more to be surgeons. And so, like in our clinic, we have well trained optometrists who do the basic health care, and then we work as a team to get everything else done. So, even in my routine eye care, I have one of our optometrists do it. So I would say you need to be with an eye specialist, either an optometrist or an ophthalmologist, um, and you should be in good hands. Uh, that's what I would do.
Thanks. Bob Bell, Martha, what were your OGTT results from last week? So Martha shared that she was getting her OGTT. She also shared that she hasn't heard yet. I have to make a comment. I had a viewer ask on the channel, I think it was last night, Doc, once you actually learn what's involved with an OGTT, why aren't people getting it at home? And my point was, we are getting it home. A lot of people on the channel are doing their own. In fact, I did a video a couple of years ago where I did an OGTT using Mott's applesauce. And the purpose for that was people think that, oh, apples are healthy for you and applesauce is healthy for kids. Well, each of those little packets of Mott's applesauce had like 26 grams of sugar in it. So I used I used 3 of those little cups and my blood sugar just went out the roof. So there were 2 points to that. It's very simple, very easy to do your own OGTT. Now, an OGTT is not going to tell you your insulin values. You need to go to a lab to do that. There's a lot of work developing home access to finger stick insulin, but it's not ready for prime time yet. Despite that, you can get a lot better information with just a simple finger stick glucometer and a source of sugar, and tell yourself a lot more about your own insulin sensitivity and resistance than the vast majority of docs are telling their patients these days. Jason Wells, all I can think of is the song When Irish Eyes Are Singing, oh, and roll out the barrels. Martha Reich, is it possible that the reason for difference in blood glucose and interstitial fluid, including the normal time lapse, is insulin resistance? Question continued. Possibly the insulin isn't yet getting the glucose into the cells, so the cell fluid reading is lower because of that. Any comments on that, Craig, before I take a swat at it?
I refer that to you.
I think Martha's talking about the Freestyle Libre. Are you familiar with that?
Oh, I'm getting one for myself.
Excellent. Glad to hear.
I listened to one of your podcasts and I said, I need better information to take care of myself.
Well, great. I'm glad to hear you thinking about that. It's sort of like we've gone through 60 years of our lives without a dashboard, without knowing what speed we're going.
Yes.
One of the most important things we can know for our health is what our blood sugar's doing. And finally, it's available. So, Martha, there's several things in terms of, yes, it looks at extracellular fluid instead of capillary blood. That causes a thing called the train or choo-choo phenomenon, where you tend to get about a half-hour lag. There's some other things there too, and I'm not, I am sure I'm not going to be able to answer the detail of your question. Some of which, because I don't understand it. Some of it, which is a little bit technical. So, Chow, CEO. By the way, do you know who Martha Reich is, Greg?
Forgive me, I don't.
She is James's aunt.
Oh,
Chow, CEO. What was the name of the eye supplements that were shown on the screen? It was a bottle named
oxyfolin. It's a medical food that if you're interested in getting it, drop a note to info@ocufolin.com, and we'll try to connect you with a doctor that will write the prescription for it.
Are you able to see that on the screen?
I'm able to show it.
I've got it on the screen right now.
Got this.
Ben, if you will show my screen.
Yes, right there.
Ocufolin.
Ocufolin.
And I take Restore Me. Again, the differences between Ocufolin and Restore Me are what?
It's pretty minimal. The primary, the way the formulation registration of Restore Me is, it's an over-the-counter supplement that anybody can get without a prescription. Ocufolin has to be dispensed under a physician supervision because it's a medical food.
And the difference is the amount of
the Ocufolin doesn't have alpha lipoic acid in it, and or in acetylcysteine.
Very good. So let's see. Bob Bell, maybe Ocuvite, Ocufolin, a lot of back and forth about that. And Chuck Rogers, finally start taking 5 milligrams of Crestor, 67, low BMI, elite fit, low carb, and a calcium score of 500. Thanks for keeping me inspired. You're very welcome, Chuck, and thank you so much for taking interest. I don't know what languages you speak, Craig. Are you able to interpret that?
Sadly, no. I wish I could.
Tom Herman. Good morning, docs. When I have a dilated eye exam, what should I ask the optometrist?
You want to know what your eye pressure is. You want what your visual acuity is. You want to know, is the optic nerve healthy? Are there any signs of aging in the macula? And are the blood vessels all look healthy?
Thank you much. I'm going to have to run us through. I have a 12 noon meeting that I cannot miss or be late for. So Priya adds to his earlier note, Sirko Hind ni ati me to India sehu. Again, I hope I didn't butcher that too much. Robert Simpson, what's the difference between an ophthalmologist and an optometrist?
Well, as an ophthalmologist, I went to medical school just like Ford and did then did a year of general medicine, then did a 3-year medicine and surgery residency. An optometrist finishes college and goes to a 4-year optometry school, which is dedicated to dealing with medical eye health and dealing with healthy eyes, heavily into refraction and contacts and glasses and that sort of thing. But also increasingly they're into medical care, but the surgical care and the really most complex medical care is usually still done by the MDs because we're grounded in the eye as part of the whole body because we've done 5 years of general medicine before we went into this.
Thank you so much. Speaking of doctors, Kevin McCord joins us, and he said, good morning. Great topic today. Greetings from your friends here in Northern Kentucky. Never ceases to amaze me how people assume they are healthy by default in the absence of a diagnosis. Vagabond Sojourner, Dr. Brewer's the best. Thank you so much, Vagabond. Content of this channel just gets better and better. Well, I think a lot of the credit goes to Craig here and Dr. McCord and James and getting some of our visitors. Josefina Lopez, are there eye exercises you recommend? And I think we'll have to finish with that.
You know, the most I would say would be there's some like Tibetan exercise and things where you look to the left, look to the right, you look up and down. As you get older, you forget how to look upwards, and people's eyes won't go up very far. So it doesn't hurt to dip your head and look up real intensely a couple of times a day, and keep exercising that up gaze. That's about it.
Thank you so much for joining us today and sharing that information, Craig. That was wonderful. And thanks to the guys that attended. Thank you for your interest.
Thank you all. It's an honor and a privilege.